In this video, we're going to be looking at special tests used to diagnose an ACL tear, or a tear of the anterior cruciate ligament. Now, for an ACL tear, there's a couple common mechanisms of injury. The most common by far is a closed chain rotational mechanism. What does that look like? Well, let's suppose somebody's running up to dunk a basketball. They dunk it, of course, and they land, so their feet are planted on the ground. But for whatever reason, on one or both of the knees, there's a rotational torque while their foot's planted. So you've got all the force from landing combined with rotation, and if that rotation occurs with enough force, well, then it can rupture the ACL. Okay? You can also have a hyperextension type of injury, but this is not near as common as a closed chain rotational mechanism. And that closed chain rotational mechanism normally implies a non-contact injury. Non-contact meaning someone didn't hit your knee from the side or the front. The rotational component from gravity and the landing and the pivoting, that's what actually causes the injury. So most injuries are actually non-contact in nature. Okay? And when somebody has an ACL tear, oftentimes they're going to have pain, they're going to have a significant amount of swelling, and they're also going to complain of instability when they're weight bearing. Okay? So all those things combined would lead you to test for an ACL tear. So the special tests we're going to be looking at in this video are Lachman's test, the anterior drawer test, the lever test, also called Lely's test, and then the pivot shift test, sometimes called the lateral pivot shift test. Now, there are some important considerations when doing these ACL special tests, and one is the timing. And the timing is important because when you're interpreting the results, if you perform the test at a particular time, it may increase the risk of a false negative. Okay? So these ACL special tests are best done either immediately after the injury, so right there on the field when the injury occurred, or about 2 weeks after the injury occurred or more. And this is because initially after the injury, there's not any swelling. There's not any muscle compensations because it just happened. It takes a little bit of time for that swelling to get in the knee. And if you wait a little bit of time, like a day or 2 days after the injury, there's probably already a lot of knee swelling in there. And you might also have some compensatory hamstring tightness and muscle guarding that occur, and that can increase the chance of a false negative. Okay? Those hamstrings, they exert a posterior directed pull on the tibia. We're going to see that a couple of these tests, particularly Lachman's and anterior drawer test, we want to see excessive anterior glide of the tibia. Well, if the hamstrings are compensating by pulling posteriorly, that's going to increase the risk of a false negative. And again, with knee swelling, particularly that joint effusion, that's going to take up space. It's going to limit the amount of anterior glide, again, increasing the risk of a false negative. Now, if you look at the mechanism and you see it happen and you're pretty confident it's an ACL tear, then by all means perform ACL special tests right there. But if you didn't really see the injury very well and you're not entirely sure what it is, it's generally recommended to quickly rule out a PCL tear before doing these ACL special tests. We'll be covering those in a future video. Those are the posterior drawer test and the sag sign test. Quickly rule out a PCL tear before doing the ACL special tests. The first special test we're going to be looking at is Lachman's test. So Lachman's test is performed with the patient in supine, as you see right here, with the test side knee bent to about 20 to 30 degrees of flexion. The PT is going to firmly grasp the patient's distal thigh, that's going to be the stabilizing hand, and also the proximal tibia at the tibial plateau with their testing hand. Okay, so let's take a look at that right here in the first video. So my left hand here, that's what's stabilizing the patient's femur. And then my right hand here is going to first take up the skin slack around the patient's calf muscle, and then I'm going to wrap my hand around with my thumb basically on the tibial tuberosity. And once I have a firm grasp on the patient's tibia around the tibial plateau, I'm going to exert an anterior glide to the tibia with my testing hand. So here's a series of anterior glides. And I'm assessing for the degree of joint laxity. So a negative test, which of course would be normal, would be painless with no associated excessive laxity, meaning excessive anterior glide. A positive test would be indicated by excessive joint laxity, specifically excessive anterior translation of that tibia. And normally in the context of the ACL or the PCL for that matter, we usually term that a mushy end feel. That's one term that you'll see. Here's another view of Lachman's test from the side. So again, there's my stabilizing hand going around the patient's femur. And then with my testing hand, I'm going to use my fingers to take up the skin slack on the calf muscle and place my thumb on the tibial tuberosity. And you can see there those anterior glides given to the tibia, about the tibial plateau. Now, Lachman's test has two sets of psychometric values. The first set here on the left, this is when the injury occurred less than 2 weeks before the assessment. So let's say a patient injured their knee on the 1st of the month, and then you assess them a week later. Well, that would certainly fall into this criteria right here. So the sensitivity in that case is 78%, and the specificity is over 95%, meaning that if you have somebody who has an injury to their knee on the 1st of the month, and on day 7 of that month, Lachman's test is positive, that means there is a 95% chance or greater that they have a tear to their ACL. You can see over here on the right, this is another set of psychometric values for when the injury occurred more than 2 weeks before the assessment. Okay, so again, person injures their knee on the 1st of the month, but you test them 30 days later. Then you would use these psychometric values, although they're not that different. The sensitivity increases to 85%, and the specificity, again, is over 95%. Let's take one more look at this test. The second ACL special test we're going to look at is the anterior drawer test of the knee. There's also anterior drawer test of the shoulder and the ankle. So again, if you're talking about this very generally, you want to specify of the knee. This test is performed very similarly to Lachman's test, but there's two major differences. One is that both hands are testing hands here, so the hand placement's different. And then compared to Lachman's test, which has the knee at 20 to 30 degrees of flexion, now in the anterior drawer test, the knee will be at 90 degrees of flexion. So again, the patient's positioned in supine with their test side knee at 90 degrees of flexion, like you see here in the video. Now, the PT is going to firmly grasp the patient's proximal tibia at the tibial plateau, and this is done with their testing hands. This should really be plural here, because both hands are going to wrap around the patient's calf, unlike in Lachman's test where one hand is used to stabilize the femur. Not written here, the PT will also sit lightly on the patient's foot, and this is basically to prevent the foot from coming off the table, to basically stabilize the distal lower leg. Okay? Now with both of my hands here, I'm going to wrap around the proximal calf, take up skin slack, and my thumbs are both going to be on the patient's tibial tuberosity. And then, just like with Lachman's test, we're going to exert an anterior glide to the tibia, and we're assessing for end feel. Okay? Now, a negative test, which of course would be normal, would be painless with no associated excessive laxity. Again, no excessive laxity in the anterior direction. A positive test would be excessive joint laxity, specifically excessive anterior glide, and we would call this a mushy end feel. Okay? Here's another view of the anterior drawer test from the side. So again, I use both my hands, wrap around the patient's calf like that, taking up the skin slack, and then both my thumbs will be on the patient's tibial tuberosity. And then I'm going to assess the degree of anterior glide. Now, like Lachman's test, the anterior drawer test has two sets of psychometric values. The first set here on the left is when the injury occurred less than 2 weeks before the assessment was done. In this case, the sensitivity is much worse. It's only 22%, but the specificity again is over 95%. Again, if you satisfy this criteria right here, then if there's a positive test, there's a 95% chance or more that the patient does have an ACL tear. And once again, another set of psychometric values here for when the injury occurred more than 2 weeks before the assessment. In this case, the sensitivity increases to 41%, so still not great, but now the specificity is all the way up at 98%. Let's take one more look at the anterior drawer test here. The next ACL special test we're going to be looking at is the lever test, also known as Lely's test. Lely's test is performed with the patient in supine, as you see right here. And for the sake of this video, I'm going to be testing the right knee. Okay? In real life, if I was doing this in the clinic, I'd want to flip around to the other side of the table so I'm on the same side as the knee that I'm testing. But of course, for the sake of filming, so you can see everything, I'm positioned over here. Now, to perform the lever test, the PT will place their fist under the patient's proximal calf. Okay? So let me get in position here. And you'll notice there that my fist is approximately 1/3 the distance from the knee and 2/3 the distance from the ankle. Okay? So that's approximately where you want to put it. If you put the fist too distally or too proximally, it can change the result of the test. So this is about where you want it. Okay? Now, with my other hand on the patient's distal thigh, I'm going to apply a downward force on the patient's femur. Okay? Notice when I do that, when I push downward on the patient's femur, her ankle rises up. It actually forces the knee into passive extension. Okay? So that's what I'm assessing for. Passive knee extension and associated elevation of the foot and ankle off of the table. Now, in a negative test, which of course is normal, that would be where there's no injury to the ACL. The ACL is intact. As long as the ACL is intact, you're going to get this passive knee extension, which should also be painless. Okay? If the ACL is not intact, that should yield a positive test. And this is where the knee extension does not occur. So when I push down on the patient's femur, in the case of a positive test, the ankle is going to remain in this position even when I'm pressing down. Okay? And depending on the grade of the tear, pain may also occur. It would not occur in a grade 3, but in a grade 1 or 2 tear, it might. Okay? Now, the psychometrics of this test are kind of the opposite of what they are for the other special tests. Generally speaking, for most of the ACL special tests, the specificity is very good. In this case, for the lever test, the specificity is very poor. It's only 25%. But the sensitivity is actually pretty good, 86%. So in other words, somebody comes in complaining of knee pain, maybe some instability, maybe a rotational mechanism of injury, and you do the lever test and it's negative. That means there's an 86% chance that they do not have an ACL tear. However, you probably want to confirm that result with several of the other special tests and kind of corroborate the results. And now, the last ACL special test we're going to be looking at is the pivot shift test, also called the lateral pivot shift test. This test not only is designed to evaluate for the presence of an ACL injury, but it's also designed to reproduce the same feeling of giving out or instability that patients often have when they're suffering from an ACL sprain. Okay? So to perform the pivot shift test, the patient's going to be positioned in supine, as you see right here. The other knee over here can be bent up or it can be straight down in full extension. But in any case, the test side lower extremity, which in this case is the right side, needs to be about 20 to 30 degrees off of the table, and we're going to begin with the knee in full extension. So I'm going to first lift up the leg, like you see right there, about 20 to 30 degrees off the table. And then, part 1, the PT is going to firmly grasp the patient's lower leg with one hand, that's what you see here with my right hand, and we're going to apply tibial internal rotation and also apply a valgus stress to the knee. So let's see both of those. So there's the internal rotation, and then with my left hand, I'm applying a valgus force to the lateral knee joint line. Now, if the person has a healthy, intact ACL, so it's going to be a negative test in that case, nothing significant should happen here, okay? But for a positive test in this first part of the pivot shift test, this internal rotation of the tibia combined with this valgus force at the knee should produce tibial anterior subluxation. So the tibia should actually shift, thus the name of the test. So the bottom line right here, if the tibia subluxes anteriorly, that's one sign that you've got a positive test and therefore an ACL injury. Now, while maintaining these forces, the PT is then going to move the patient's knee into flexion. So we're maintaining that internal rotation and the valgus force at the knee, and we're going into flexion. Okay, that's part 2 of the test. Now, in the case of a negative test where there's a healthy, intact ACL, first of all, there wasn't any tibial anterior subluxation at the start when the knee was in full extension, and therefore, if there's no initial subluxation, then nothing else of any significance should happen when we're taking that knee into flexion. But in the case of a positive pivot shift test, again here, initially we would have that tibial anterior subluxation, but then, assuming a positive test, the patient's tibia will relocate at approximately 30 to 40 degrees of flexion. And that's what we call tibial posterior relocation, the opposite of anterior subluxation. So initially here, at full extension with internal rotation and a valgus force at the knee, we may get tibial anterior subluxation. But then moving into flexion, probably about right there, about 30 to 40 degrees of flexion, the tibia will relocate posteriorly back into its normal position. And this has to do with tension on the IT band, which at this particular hip flexion angle helps to act as a knee flexor. Okay? So again, a negative test, which would be normal, so intact, healthy ACL, this is going to be painless and there's no associated subluxation. And of course, if there's no subluxation, there will also be no relocation later on. But in a positive pivot shift test, we should get that subluxation in knee extension and the relocation in about 30 to 40 degrees of knee flexion. So let's take one more look at this test right here. So again, we bring the test side lower extremity to about 20 to 30 degrees off the table like this, with the knee in full extension. Then we apply tibial internal rotation and a valgus force at the knee, and then maintaining those forces, we move the knee through flexion. Now obviously, if the potential relocation of the tibia occurs at 30 to 40 degrees of flexion, you have to take them to at least that value. So my recommendation would be take them at least to 60 degrees. Okay? Theoretically, if you've taken them to 60 degrees, that relocation, if it's going to occur, will have already occurred before you get to that angle. So you need to make sure to get at least to this degree of knee flexion. And for the psychometrics of this test, you can see it has very poor sensitivity. So this test should never be used to rule out an ACL injury. That's more reserved for the lever test, also called Lely's test. But you can see here the specificity is very good, 98%. So again, if somebody has a positive pivot shift test, there's a 98% chance that they do have an ACL tear. Thank you for all your support. Be sure to check out my Instagram for cool science and not science stuff.